welcome to the 7th Annual Interprofessional Education and Practice Day here at UTMB. We're really excited to have you all here. And I do just want to say that our first IPE Day here at UTMB occurred just after Hurricane Ike. And I don't think any of you were here then as students, because I certainly hope you wouldn't still be trying to get through your program here at UTMB from that day. But it was very sad. We had all this damage around us, and still we got together, and it was an evening presentation, and we talked all about what had happened to us in the storm and how we came together as different professions and were able to come back. And now you see these 7, 8 years later, how UTMB is so absolutely wonderful and all the extraordinary things that were accomplished, and they're accomplished because of our interprofessional endeavors. So let me just say that I'm Pamela Watson, and I'm Dean of the School of Nursing, and my second job here at UTMB is to be Vice President for Interprofessional Education, and that's why I'm here today. And I wanted to just begin by, first of all, thanking Shelley Smith, who's probably out in the foyer there, but Shelley's our Director for Interprofessional Education, and she made this day happen, and we're very grateful to her. I also want to thank Dr. Carol Wiggs, who's in the back, who's our lead faculty member. And I want to thank all of the people who are here who volunteered to do workshops today. We worked very hard to get the best workshops assembled that would really engage all of you as members of different professions, all here at UTMB, to become the best you can be in healthcare providers, health sciences, whatever you're doing here at UTMB, we want to make these workshops really relevant for you. I want to, since this is Interprofessional Day, sometimes you don't always know who the leaders are in schools other than your own. So let me introduce Dr. Elizabeth Protas, who's here. Will you stand up, Dr. Protas? Dr. Protas is Dean of the School of Health Professions. So she has many disciplines in her school. And Dr. Jose Barral is here from Graduate School of Biomedical Sciences. Dr. Barral, are you here? Well, he's going to be doing a workshop for us, and we're very happy for him to be participating, because when we first started all this, people in the Graduate School of Biomedical Sciences had a difficult time seeing how all of our interprofessional activities related to them. But because of Dr. Barrow, we've really been able to get the graduate school engaged in all of this, and we're very happy about it. So once again, I thank everybody who came together to make this wonderful day possible. And now I'm going to have the honor of introducing Dr. Vic Serapina to you, who is our keynote speaker today. And he has a very illustrious biography, and I'm going to read it to you because, as I said to him, it really makes him come alive. And I told him I'm leaving out the gig he did for Saturday Night Live. I promised him I wouldn't mention that. I made that up, just to make that up. Okay. But he could do it. You'll see he's very entertaining. Okay, so just to start, Dr. Serapina is board certified by the American Board of Family Practice, and he's a founding diplomat and director of the American Board of Integrative Holistic Medicine. He's a founding member of the University of Texas Medical Branch Academy of Master Teachers. He's practiced in holistic health centers, worked with groups specializing in home birth, and was a medical director of a group practice and urgent care center in the Chicago area. Fulfilling a life dream, he practiced what he has characterized as whole person medicine as a country doctor in a remote town of 63 people in the mountains of Colorado. While he was there, he was the medical director of Monarch and Wolf Creek ski patrols. Now, that must have been a difficult assignment, as you can imagine. And the local ambulances services before joining the faculty of UTMB in 1996. His practice and his personal life have long included Tai Chi, acupuncture, meditation, and spirituality in medicine. His practice also includes Chinese and Ayurvedic medicine, nutritional, herbal, and mind-body approaches to health and healing. Dr. Serapina was principal investigator on a large National Institutes of Health Center for Complementary and Alternative Medicine grant to develop evidence-based curricula in alternative therapies. He's also been the recipient of a $1.35 million NIH grant in mind-body medicine to create an expanded research infrastructure in mind-body medicine at UTMB. He's had many research experiences and many grants of which he's quite proud. Most recently, he's been awarded a Texas Higher Education Coordinating Board grant on the expansion of primary care medicine. Dr. Serapina is also a well-known author, and if you read the Galveston Daily News, you'll also have the opportunity to read his column, which appears there weekly. Overall, Dr. Serapina is a stellar member of the UTMB Family Medicine faculty, where he is a professor, and we are thrilled that he accepted our invitation to be the keynote speaker today. And with that, Dr. Serapina, I invite you to the podium.
Thank you, Pam, for that wonderful introduction, just how I wrote it. Okay. I was actually somewhat shocked when they asked me to give this talk, because this is something I've never really given a formal lecture to, so if it gets boring, people leave, it's okay. But it's actually, when I asked them why they asked me to do this, they said, it's because it's what you do. And over the years, I had a lot of experiences, and I'll share those with you that would fall into this term interprofessionalism. And that just seemed like kind of part of the way that I did my work. And now it's going to become more formalized in terms of our training students into interprofessionalism. So what does this term really mean? Well, what we're going to do is I'm going to go over a definition of it. We're going to look at various goals of interprofessionalism. I'm going to list some examples from my personal practices over the years and some other areas that I'm familiar with about what interprofessional practice or education looks like. And then I'm going to ask you as a group to kind of talk to each other for a few minutes and come up with some examples that you have seen of interprofessional education or practice. And then we're going to kind of dissect this a little bit and unpack it and find out what are the components of interprofessionalism, what are the competencies involved, and what are some of the barriers to implementing this in our clinics, hospitals, and other healthcare settings. This is a great quote, and I think this will kind of set the tone for what we're talking about, by Carol Johnson from the Nursing Oncology Journal. Imagine a world where each group's experience is held in regard, offered and shared as the need arises. Imagine a time when the patient can determine which kinds of practitioners he or she needs or wants, and then imagine a system that makes those professionals available. It's kind of like John Lennon, right? Imagine. So what is it, this term, interprofessional education? Basically, it boils down to when we educate people next to each other from two or more professions. So they learn with, from, and about each other to improve collaboration and quality of care. Now, actually, the list is endless in the healthcare arena about how many other people we can or might interact with. And this is kind of a partial list from audiology to school teachers. And all of these people provide some care for patients at some spectrum, at some point on the spectrum. And they may be people that you either are or that you will interact with and need to know how to interact in a team-based way. So the bottom line, the goal of this talk today and this whole meeting today is to raise awareness and consciousness among educators and among students that our intention is trying to put you all together in learning opportunities as often as we can. So from that initial exposure and then an immersion in an experience of interprofessional care to actually applying it. But really, when I think about this interprofessionalism, it's not actually about us. It's really about the patient, okay? what we really want to do is kind of get past our individual differences, join and synergize our skills, and make the patient the center of the show. And so this term, kind of patient, client, some people use the term client rather than patient. So psychologists, for example, or nurses might say client, where I might say patient. But also as a family doctor, I understand the importance of the context of care, the family, and the community. And so we seek out all of these people to be members of the healthcare team, in a sense. And this is, the essential part of this is incorporating the patient's perspectives. I was listening to a talk on end-of-life care yesterday, and it was so revealing to me that people need to really put the patient's preferences above what anybody else thinks. Some people will have an advance directive, and if such and such a thing happens, they want this done or they don't want this done. And it's really not up to anybody else other than that patient, in discussion with their family, what those advance directives must be. So that's just an example. I often find my residents and students will go in and talk to a patient, and we'll talk together, and then we'll have a plan, and we'll say, okay, this is the plan for the patient. And then I have to say, well, wait, have you talked to the patient about your plan? Okay? Because that plan may or may not work for that patient. They need to be incorporated into the decision making, or else it's never going to go. And we've got to be respectful in terms of their needs. Now, I went to our IPE website, and there's 5 goals that are listed there in the UTMB's website. The website's there, which is knowledge acquisition. That's part of what you're doing today through this talk and workshops. Observational learning, actually seeing what this looks like in practice, and we're going to talk about some examples and figuring out how healthcare teams can and ought to work. And then participating in them, becoming a member of them, and this is a essential part of owning this for yourself. And then students also are part of our evolving quality improvement, developing, implementing projects, enhancing health and wellness, and including practice improvement, and developing leadership skills in order to figure out how it is to be a team member. Now, it wasn't always like this. When I went to medical school, I graduated from medical school in 1979, and this kind of whole patient-centered movement had really just started to grow out of the kind of social turmoil and revolutions of the 60s and 70s. But prior to that, it was medicine, I'm going to say, was kind of militarily oriented. There's kind of a command and control. The doctor was kind of in charge, and he was the boss, and many of them really liked that, you know, because people just did what you told them, whether it was a patient or nurse or other healthcare worker. But it's really started to shift, I think, in the 70s, where people started to want to be more involved in their healthcare decision making. And I think this was basically a patient-driven movement. So I had my first real experience in a interprofessional setting as a first-year medical student. This is the Union Church in Hinsdale, Illinois. It's a very wealthy suburb that's kind of west of Chicago. And Granger Westberg, Dr. Granger Westberg, was a minister of practical theology at the University of Chicago. He always used to say, well, I teach practical theology, everybody else's theology is impractical. And the way that he applied his practical theology, he got thinking, he said, okay, why are doctors' offices in a hospital? Or they're on a street corner above a drugstore, or in a professional building? Why are they there, okay? Is that the best place for promoting whole person care and wellness within the context of the patient's life? He said, man, maybe we should put them in a church. And so this church, like many churches, big old facility, often stands empty most of the week, right? There may be a few classes and this kind of thing, but they have rooms available. So his plan was to develop this holistic health center model within a church. And what was unique about this, so they corralled 3 or 4 rooms that they made into the clinic, and then they had other rooms they could use for activities, for classes, for exercise, and such. And the team, okay, would have a health planning conference. Now, this doesn't really look like a health planning conference you'd like, right? 3 people standing over you ready to tell you what to do. Maybe before surgery, that's a good thing. But the center of the health planning conference was the patient. So the process of consultation was the patient would come in, he or she would talk initially to a nurse, and the nurse would serve as kind of the navigator or patient educator throughout the entire process of care. And befriend the patient, really understand what their needs are. There was also a pastoral counselor. This is a minister, but he had a degree in psychology, clinical psychology, so he became kind of the mind-body side to help patients with their emotional and social issues. And there was a holistic physician. So the patient would see the nurse, she would have a visit with the physician and the counselor, and those 3 things would happen in a relatively short period of time. It may be 1 visit, long visit, or a couple of different days. And then after labs were done and after any other testing was done, there was a health planning conference. And what was unique about this model, and I think this is something we could do better today, is the team doing the health planning conference wasn't the doctor, the nurse, and the counselor only. The patient was at the table, okay? So the patient sat at this round table, and they made a very good point of making it a round table. So there was not this kind of positional power shift. And we would come up with a plan and bounce it around with the patient and detect, well, are these resources available? Is this plan in terms of your lifestyle or your medications or your management of whatever illness or wellness goals you have? Does this make sense? So it's very empowering to put the patient at the center of that. And I think this was my first really good exposure to an interprofessional model that really put the patient at the center. When I was a resident, we got pregnant. And when I say we, shared experience. And my wife was a registered nurse, and she had been in hospitals enough to say, I don't want that kind of delivery. At that time, episiotomies were very common, and full anesthesia, stirrups. It was a very operating room type of experience. So she wanted to have a home birth. And since she was the one going to be delivering, I said, that's fine. I didn't have much experience with it. But there's a group in Chicago called Home First. Now it's called that. It used to be called Family Practice Unlimited. And they had another interprofessional team. And the key member of the team, besides the patient and her extended family, was the advanced practice midwife. And the advanced practice midwife was the first person on the scene when the patient went into labor, but also saw the patient for her prenatal visits. And there was also a physician. The physician would go to the delivery, and sometimes the delivery already occurred before he got there. But we had a couple of our kids at home, and I worked with this group for a while, and I realized how important it was to have somebody like an advanced practice skilled midwife there in terms of alleviating patients' anxiety about home birth. And I attended a number of deliveries, and it was fascinating watching, some of these people already had kids, and they wandered in and out of the bedroom while the birthing process was going on. It was all very natural. There was no anesthesia used. If a patient received anesthesia, that made them more of a high-risk person, and we had very great outcomes. And it was really, again, that patient-centeredness and family-centeredness in the home birthing experience. We received a grant from the Templeton Foundation about 1998 or 99 to integrate spirituality and clinical care into our training here at UTMB. And the idea that we want to know the patient's perspective on what is really of value to them in the healthcare setting, and how is it, without being preachy or kind of overly stickily religious, I guess, to bring that up. You know, and obviously if somebody's facing a life-threatening illness or something, their values about their spiritual beliefs are very important at that time. But that's also just the day-to-day things, like what do you want to be well for? What are your values? And so we put together a course which is still being offered, where we developed 4 cases, and then we bring, originally it was nursing students and medical students, then we also brought students from the School of Health Professions, and they kind of worked at tables. We'd divide up the students. We didn't have all the nurses over here, but have the medical students here. They all kind of mixed at the tables and worked on these cases. And it's very interesting to hear the perspective of the nursing students, which was often actually much more patient-centered than the medical students in this. So that was that's an ongoing course that we've had, and it's something I'd like to see more kinds of programs like that. Now, another interprofessional type of model are student-run clinics. I was recently in Atlanta at the Society of Teachers of Family Medicine, and the winning poster by a student was a group that had a interprofessional team model, where they would have the patient would be seen initially by a nursing student, then a physician assistant and medical student would take their history and do the exam. There would be a clinical laboratory student there to draw blood. There was a occupational therapy student who ended up seeing the patient towards the end of the visit. And so this whole group, they kind of handed the patient to the next person, and then they met together as they developed the plan. St. Vincent's is our student-run clinic here at UTMB, and they also have this kind of a mix of students. We've got clinical laboratory, PA students, nursing students, medical students, all kind of working together for our patients. UT Health Center in San Antonio, I just saw a poster at another session I was in Austin, and they have dental students as well. And so they provide dental hygiene instructions along with the medical visit, and they also have nursing students, PA students, and medical students working in a team. So these are places where you actually get that application of experience, where you are immersed in it. This is a term you probably have heard, the patient-centered medical home, and family medicine was the first UTMB department to actually have this qualification. It's a nationally defined set of competencies that you have to be called a patient-centered medical home. But this is the general concept is everybody in the office works to the top of their license. So we have medical assistants, LVNs, RNs, MDs, as well as our staff, phlebotomists, and so forth. And it's really much more oriented around team care of the patient and keeping the patient at the center. And this quote I kind of like: the patient is really the expert in what the condition and treatment mean to them. Again, kind of back to that spirituality concept. What's the meaning of this particular condition to you, and what do you want to be your outcome of the treatment, and putting that at the center. There's another school that I'm aware of. This is just one example. Pamela mentioned our National Complementary Alternative Medicine Curriculum Grant. Oregon Health Science University in Portland also received such a grant, and they have the luxury of having multiple health profession schools in Portland. So they've got a naturopathic school, a chiropractic school, and a traditional Chinese medicine school, and a medical school. And so they have these students sharing classes and clinical experiences from all 4 different professions, and learning how to cross-refer and what indications might you send somebody to an acupuncturist for, or a naturopath, and how those professions function. At UTMB, we've had a complementary and integrative medicine elective as well as selectives for many years, and our students go and get a massage. They go to the chiropractic clinic and get an adjustment. They go to the health food store and find out something about supplements from the people that run the health food store. And they work with a variety of different practitioners in the context of their selective. And then this is something that my wife runs, actually. It's called the UTMB Osher Lifelong Learning Institute. And this was originally set up as an adult learning setting for seniors 55 and older that provide college-level classes. So these are free-living, generally highly functioning seniors, and they have classes on fitness, and they have classes on religion and art and bird watching. And it's actually evolved where it's also become a site for geriatric fellows and students that are on geriatric rotations. Our community medicine rotation for our residents goes there. There's a number of research initiatives in the School of Nursing and allied health professions, as well as medical school projects. And this kind of intergenerational learning. The students come and they find out that these 75 and 85-year-old people do yoga, and they do it like 3 times a week. And the student comes and they can't even get out of bed the next morning because they tried to keep up with these old people doing yoga. But they like it, and they come back even when their rotations are over. So those are just some examples from my experience, and maybe you have other things in mind when you think about interprofessional health. So I'd like you just for a couple of minutes here to turn to the person next to you, find somebody next to you if you don't have somebody, and just describe an experience that you know of an interprofessional education or practice experience. And then the other person can switch. We'll just do it for a couple minutes, and then I'm going to just ask for a few little examples from the audience, so you've got a point of a spokesperson, okay? We'll have some microphones. Yeah, she can. She can. Okay. All right. So she didn't talk to anybody else, but you're going to tell us something, okay? Go ahead.
Oh.
Yes.
Oh my gosh. Okay. Hi everyone. I volunteered at the St. Vincent's House Clinic just once, but what I noticed was it was a various team of different healthcare professionals, such as a physician assistant, nurses, nursing students, CLS students, and basically what we did is we took care of the patient medically, of course. But what I did notice is that after a while, after we did the chain of command and all those things, we actually took care of his emotional needs and his behavioral needs as well. So it was really a great experience, holistic. I was happy because I know that we gave him a referral and he'll be coming back. So yeah, so he's going to be followed up with his medications, and his mind is being taken care of. So it's basically mind, body, and spirit, and that's what I enjoyed the most. So.
Perfect. Here, you give the rest of my talk. Okay, that's good. Perfect. That's a perfect example. Okay, thank you. Anybody else? Don't be shy. There we go. Thank you.
UTMB has UTMB has a grant, and they basically get medical students and nursing students together to go to homes of families they're in the CPS program because they were either medically negligent or there's some sort of abuse going on. And so we would go with med students and assess our child as well as the family and determine what sort of needs they or what they needed both medically and psychologically. And that was really a great experience.
So that's a very nice example. I just gave a symposium on home visits, and there are different models around the country, but the nurse and doctor going out or a social worker often is involved. If you're looking at end-of-life care, the hospice team involves a pastoral counselor, a visiting nurse, a health aide, physician, a nurse. It's a whole team of people. So that's another good example, okay? One more person. Anybody else want to? Thank you. Okay. Some people are just like me, shy, talking in front of audiences. Okay, well, all right, we'll move on. So this is really about collaboration, isn't it? It's really about figuring out how to partner with other health providers who have skills that are sometimes the same and sometimes different than yours in the service of a patient with, again, back to this notion of shared decision making. And it's not just health issues, it's social issues. You'll find in your practice setting that social issues often trump medical issues. The context of the patient, the context of the care is often very much colored by the patient's family, their work, their economic status. Many people with chronic illness are disabled and they live in poverty or near poverty conditions, family disruption, abuse, substance issues. She mentioned the CPS, the child abuse, those kinds of things. These are all very critical parts of deciding what we're going to do with patients and how we're going to approach them. And that's why we need a team approach. It's not just one person, the physician, deciding what this patient needs. And in fact, I can't do that. It's like not possible for me to provide all of those resources. So we do heavy use of our social workers and our nurses, our home health nurses and such to care for patients. So, and this is never more true than it is with chronic care patients. People more and more are living longer. They prefer to stay at home if they can, and often they are, maybe after hospitalization, they're in need of skilled nursing, they're in need of closer monitoring so they don't get readmitted to the hospital. And so we use a lot of home services to coordinate for chronic care. Other specialties, of course, you can administer physical therapy, not only in the physical therapy suite, but also home settings, occupational therapy, nursing care, pain management. All of these things can be done and require coordination. Now, I, as a physician, end up signing a lot of papers that are orders that these things need to get done, but I'm very dependent on the people that actually deliver those services. So there are some key elements to this, and we're going to talk a little bit about components and then barriers, but really it comes down to respecting and trusting, okay? Respect means I respect myself and I respect you. I respect the skills that I've learned, but I also appreciate that you have different skills and that I trust that your intention, which is the care of that patient, is the same as mine. Our goals are to collaborate and pull together to put that patient together. And if I hand off a task to you, it's because I think you can do it better, and I trust that it gets done. I don't have to go back and check on you. And this, of course, requires us to know about each other's skills and each other's roles. And that's why these kinds of gatherings are very important, because we work with people from different schools and we start to understand how they are trained and what they do. So, for example, one of our student electives, the integrative medicine, complementary integrative medicine, we send students up to the chiropractic college up in Pasadena, and they find out there's amazing similarities between what chiropractors learn and medical students learn. They learn anatomy, they learn physiology, they learn pharmacology. So it's a real eye-opener when you talk to people in different professions and find out what their scope of learning is. And teamwork. Teamwork is not something that happens automatically. It's, again, a conscious and intentional process of developing a team, and a team doesn't just form once and then, it's running. As any of you have played sports, it's a constant maintenance thing. People are coming in and off of the team. People have different issues, different skills, different communication issues. Conflict resolution is a part of it, and we're going to talk about that a little bit. Placing the patient and improving the outcome is at the center of this process, and then again, understanding each other's roles with communication and language. I was telling Dr. Watson when I first came to UTMB, I got my first lesson in politically correct language from my nursing colleagues because I was using terms that were kind of antiquated from the old school of Colorado, I guess, wherever I was practicing. And even now, like at lunch, she said, we don't call them mid-level practitioners. You'll get shot for that. So I was between her and Dr. Protis, and they go, no, these are advanced practice practitioners. Say it again? Advanced practice clinicians. So don't say mid-level practitioners anymore, especially between those two ladies. They're tough. Okay. All right. So what are the issues? There's kind of power differentials. If you think about this, it's like the physician in the healthcare setting, the surgeon in the operating room, whatever. Ultimately, we're responsible for things, and the system has kind of been oriented around that. So if things fall, ultimately you're responsible for it, then in a sense you're empowered at a different level than other professionals. And kind of working in a team requires us to be a little bit more humble and step back from that. This languaging and communication issue is one. There's kind of inevitable turf wars. I do this part of this, and somebody else does this part. There was in the early 2000s, for example, there was almost nobody from medicine going into anesthesia. And the reason was that the nurse anesthetists had kind of really taken over a lot of the operating rooms. And people said, well, I don't really want to be an anesthesiologist because the nurses are taking that over. So that has finally settled out, I think, but that's often a case when you are in a situation where one person's group is used to doing something and another group infringes on it a little bit. I think it's important, the issues of relationships versus tasks. How you relate to someone and what kind of relationship you have with someone on your team is kind of separated out from the tasks that are important. And a lot of times it's more important to focus on the task, but other times you really have to focus on the relationship so the communication happens. And I see this a lot. For example, many of our medical assistants are at a very different socioeconomic status than even our medical students or residents, and they have different communication styles and backgrounds. This requires cultural awareness and sensitivity. How about socialization? Why is it that I call my medical assistant Mary and she calls me Dr. Serpina? Right? Seems normal, but is it? If you're in a team group, why wouldn't I be Vic? We're sitting around talking at a table. Hey, Vic, what, Mary? I didn't like what you did over there. And I go, oh, okay, tell me more about that. So subtle things like that work into the communication process and maintain some of those power differentials and things that keep a team from functioning optimally. Some clarity of role. Who's going to do what? Okay, who's responsible for what? That's very important. So A, work doesn't not get done, but B, it doesn't get done twice or three times and wasting a lot of issue. And patient-client centeredness. So our socialization prevents us in some sense from learning how each other's practices are with patients and clients. It's the way that you've got the nursing schools over here, allied health professions here, medical schools here, and how often do we really get together because our education doesn't foster that kind of socialization. And we might actually have incorrect thoughts, myths about those people who are outside of our particular group. Oops. So keeping this in mind, that each of us has unique and shared knowledge that we might have. So the cardiovascular surgeon is going to do his surgical thing on the heart, but then the anesthesiologist, and then somebody's going to run the bypass pump, and then the nurse that is handing him the instruments. They all have different roles, and this is an important part of sharing their knowledge, their skills for the benefit of the patient. So this interaction becomes collaborative with clarification of roles, respecting each other, working together with the shared goal of patient outcomes. We had a wonderful presentation by Carol Orchard, who's from Western Canada University in Ontario, Canada. And Canada has a nationalized healthcare system, so they actually have really done a lot in this interprofessional education and practice in terms of establishing competencies and establishing role models. This little flower here talks about the different components of that. The goal of interprofessional development is surrounded by issues of conflict, team functioning, leadership, role clarification, as well as overlaid with processes like quality improvement, moving from simple to complex tasks, and working with patients in a variety of contexts. So the interprofessional collaboration or communication, we learn to be responsive and responsible to each other. We work on team communication principles, active listening. I think one of the most difficult things is active listening rather than and this is true of patient interactions as well as team interactions, rather than thinking what you're going to say next while somebody's talking, just being really receptive and all ears and listening through to the person. And people will get these kind of subtle cues that you're not really listening because you're kind of looking at the watch and you're holding your breath ready to say something. And so being respectful of patients and other team members by active listening and communicating and checking that we have the same understanding about what we're talking about, and then building those trusting relationships. The role clarification, as I mentioned before, understanding your role and the ones of the other team members and how those can be applied. And part of this is just describing your own role to others. Like, how would you describe what you do or what you think you do? And recognize that maybe others don't see you in quite the same way you see yourself. So that requires respecting diversity and that kind of cultural respect that we talked about. Team dynamics, we already mentioned. What makes a good team work? If you look at the business literature, there's lots and lots of interest in this whole topic. If you look at top functioning companies like Apple and Google and other big companies on the Dow Jones Industrial, they really are very concerned about teams because you have an organization that stretches across multi-nations, multi-states, and hundreds of different divisions. Teamwork is the only way that really happens. And the same is true of healthcare, and we're talking kind of more on a micro level in many cases when it comes down to the individual patient, but also on a macro level when it comes to the healthcare system. So developing some skills in this is kind of like what you do in business school in a way. How do you work on the process of team development? What are the principles of working together? How do you facilitate discussions? And also reflecting on how the team is functioning. So in our patient-centered medical home model, for example, we have regular staff meetings. We start off, I'll say in the morning, I start off with my medical assistant, and we go down the list of patients, and I'll say, okay, these are the things that with these patients I'd like to anticipate that we need to do. We need to do a hemoglobin A1C. We need that patient to fill out their review of systems. Let's check their immunization status, find out if they need refills, find out if they are needing any labs, are they fasting? So we kind of anticipate the issue. And then we come together as a group from time to time and work out problems in the clinic. Why isn't the clinic flowing? Why are patients being delayed? We've got a team of patients that are our patient advisory panel, and they'll let us know if things aren't going as well in family medicine as they'd like them to do. So we sit down and facilitate problem solving as a group. And then what do we do when we have conflict? And conflict is always part of just human relationships, right? Any of you married? Okay, no, never mind. I get along well with my wife. But you know, if you've had a boyfriend or girlfriend or spouse, you know that sometimes just things are not always agreed upon the same way. We look at things through different eyes. And so you've got to kind of expect this is going to happen in any kind of team, and how to handle it professionally, and how not to do character assassinations and speak to people in hurtful fashions that can be damaging to your long-term relationship, and even worse, to the care of the patient. So here's a cat and a dog. We're fighting like, well, we're fighting, okay. Not fighting like cats and dogs, I guess. So this is actually interesting. So you say value that conflict can actually be positive. It can bring things to a head. You know, sometimes the worst conflict is the one that we never hear about. People are just kind of sitting in the corner stewing, and going, all right, that son of a gun did it, and you never hear about it. So you have no chance to actually resolve the conflict because you don't know it's there. And so that can affect productivity, it can affect morale, and it can affect patient care as well. And so taking that head on, saying, okay, we've got a disagreement, let's take some constructive steps and strategies to deal with it. And to do that, let's create a safe environment within the context of our healthcare environment that we can do that. And it's been challenging, I think, in this progression for physicians to yield some of their autonomy, particularly when it comes to something like this. Physicians kind of like, well, I'm the doctor, you know. And so people will say, well, I don't want to bring that up to him because he's probably not going to listen to me about it, or he's going to maybe cause me some damage, say something bad, or give me a bad evaluation. So we have to create a safe environment, and that's something we've really worked with the patient-centered medical home. And it's really hard to get the staff to kind of break out of that mode to say when something's really wrong, they can talk about it. But usually 2 or 3 courageous people will kind of role model that for other people. Let's see. So leadership skills. This is another piece where we are, again, focusing on patient health outcomes, and each of us leads a particular part of our team or the whole team. Working with others to enable effective patient outcomes, interdependent working relationships, effective decision making, and again, this establishing a climate for collaborative practice, which is a matter of intention. So finishing up, interprofessional education is basically learning with, from, and about each other so we can improve the care we provide to our patients. And as you leave today, think about these questions, okay? Interprofessional communication, how is it similar or different from other professional communication? So I'm talking to one of my physician colleagues, and how is that different? So she was saying about over at St. Vincent's Clinic. The medical students have a certain kind of conversation with each other, but how is it different when they talk to the lab folks, or the social worker, or the nursing students? And how is this kind of teamwork different than multi-professional teamwork? Interprofessional means a lot more working together. Multi-professional or interdisciplinary is kind of, we have our little silos. I do my job over here, and I hand you a chart and go ahead and do yours, rather than working really more interactive than that. And then think about patient or client-centered care. How is it similar or different from the way you've seen practices now? Okay, and to me, I keep drumming on this because I think this is the bottom line of this whole piece, is when we make a decision, is that patient at the center of the decision? Have they been involved in it? Are they participants? Have they shared the decision making? And if we're not doing that, I don't think we're providing a patient-centered medical home. Now, as Jack Sparrow said, the problem is not the problem. The problem is your attitude about the problem, okay? So being interprofessional is really about teamwork, a way of being, and it's really a value system. It's actually creating new knowledge. It's one thing to have your own skills, but then creating knowledge, how those interact and intersect. It's a little bit like cooking, right? You have all these different ingredients on your counter, and you cut them up and chop them up and put them in. And what happens at the end, whether it's a salad or a soup or a casserole or whatever, is the synergy of all of those spices and components of the food are very different than the individual ones. So, but creating new knowledge and skills is a little bit like that. And this may, most of your students, and you don't really necessarily have a work pattern yet, but those of you that do, you may have to give some of that up. There's some old ways that maybe did work in the past but don't work as well. And so that's where being interprofessionally collaborative can be helpful. I do want to thank Dr. Orchard from the West University in Ontario, Canada. She gave a talk to the Academy of Master Teachers, a one-day symposium on this topic a couple months ago, and she and I communicated back and forth from Canada and Australia and such. Very, very helpful leader in this field, and if you want to go to her website or communicate with her for more detailed information, particularly on the competency types of issues, she's a really well-known expert.
Let me thank you. And this is a little token.
Thank you.
We just do want to thank you, Dr. Serapina. That was a wonderful presentation, and we created a little plaque, and we hope you'll put it in an important place and say that this was the best presentation opportunity you ever had. That's all we need. So look, join me in thanking Dr. Serapina for a great way to start our day.
UTMB Health, working together to work wonders.